Hi, everyone. My name is Kenneth Allen. I'm the president of the Vermont Public Health Association. I'm also a faculty member at the University of Vermont in the Department of Biomedical and Health Sciences. And I'd like to introduce Dr. Mark Levine. Dr. Levine has served as the Vermont Commissioner of Health since March 2017. Prior to his appointment, Dr. Levine was a professor of medicine at the University of Vermont, a position he still holds. He was the Associate Dean for Graduate Medical Education, and he also served as Vice Chair for Education in the Department of Medicine. Prior to his appointment as Commissioner of Health, Dr. Levine practiced internal medicine with a focus on health promotion and disease prevention. Dr. Levine has served on the American College of Physicians Board of Regents and as governor of its Vermont chapter. As Vice President and President-elect of the Vermont Medical Society, and he was a longstanding member of the Vermont Department of Health's Primary Care Public Health Integration Workforce. He successfully directed large NIH and HRSA educational grants related to nutrition prevention medicine competencies for general physicians. It's my pleasure to welcome Dr. Levine.
Thank you. This will nicely complement the presentation you just heard, and I'll make some of the same themes, but also it'll come out slightly different. So we'll keep you all awake. You can see the title of the presentation, which is the title of your conference today. And basically, my objectives will be, much like Patricia, to kind of tell you what happened before the pandemic, what the pandemic then revealed about the challenges we have in the area of health equity, understand the workforce and infrastructure challenges, talk about our state health improvement plan, which actually came before the pandemic and really outlined everything we wanted in our vision pre-pandemic. And then talk a little bit about the future vision, knowing that COVID provided a significant wake-up call to us all. So this audience doesn't need the definition of public health, but my presentation does. Obviously, the traditional definition pivots off of epidemic management, environmental health, chronic disease prevention. But that all still holds, of course, but I think we all recognize the contemporary definition is really all about we as a society, meaning not just the Department of Health, collectively assuring the conditions in which all people can be healthy. And that means abundant collaborations and intersectoral partnerships, still building on adherence to science, data, and objectivity, but a real it takes the village mentality, if you will. And public health can often be looked at in this sense as being the thought leader, the champion, the catalyst, and the entity that provides the public health lens to all of these partners and collaborators, knowing we aren't doing all the work and could never do all of the work that needs to be done in our new view of public health. So the teaser is that the contemporary construct is the vision for everything public health wants to achieve must consistently and reliably be informed by health equity. So a little bit of a flashback to the past of what kind of things I was really prioritizing and our health department was prioritizing before we knew there would be a pandemic. This one goes under the category of preserving kids' brains and really working on e-cigarettes, vaping, and reducing traditional tobacco use. So we actually, as a state, had a trifecta of policies that got passed that did a significant part of the heavy lifting, and you can see what they were. Had a significant impact already on improving the outlook for kids. And then basically said, well, what's next? We've done all that. We've got Tobacco 21, we've got laws that help improve the outcome because we're taxing the heck out of these products and not allowing them to have internet access to them underage. So we said, well, how can we go further than this and use a health equity lens to protect our youth? And of course, banning flavors and especially banning mint and menthol came up. Well, the minute you talk about flavors, mint and menthol, you're talking about health equity, because look at the populations that are disproportionately impacted by this industry that focuses on sales of these items. We know it's our youth, females more than males, African Americans heavily impacted, the LGBTQ plus community, and those with mental illness heavily impacted. So obviously, working on this problem is working on health equity in action. Another priority, Vermont unfortunately has one of the highest increases in suicide rate over a 20-year period, as shown by the CDC in a publication a couple of years ago. And we clearly needed to focus on this. Well, just to draw your attention to the bottom part of the slide, you can see that on the right-hand corner, students of color and the LGBTQ student population have markedly elevated risk of attempting suicide. I've not even shown you the data on social isolation and making plans and things, but looking at the worst part of the outcomes, significant disparities, again, all related on not looking at just the whole population, but looking at the parts that are most heavily impacted for sure. And then final example is really looking at something that is becoming more and more important for health departments that have been steeped in traditions of maternal child health, and God forbid we give that up, but now we need to be more embracing, especially in northern New England, of the fact that we are aging states, and we are the 3 most aging states in the country. So focusing on healthy aging seemed to be a very important aspect. And Patricia's slides did allude to the fact that even age is one of those items that shows disparities and inequities. So we want to create a vision of a Vermont friendly at any age, knowing our age demographic, and committing to really understanding that if you make a place a great place to live when you're older, it's also helping everybody who's younger. And it's incentivizing them to even come here and bring a family, set up a career, etc. We built our healthy aging sort of vision on the State Health Improvement Plan, which said communities support healthy aging and healthy living. And we had our mandatory state plan on aging, legislatively mandated, which basically said the primary goal is to support healthy aging for us all. And of course, you'll see a lot of initiatives in there that make a lot of common sense and are beyond the scope of this talk for me to get heavily involved in. Everyone understands the Frieden Health Pyramid, so I won't re-explain it, except to say that obviously when we look at the bottom 2 layers of the pyramid, this is what we call out, those socioeconomic factors specifically, and the ones that we know public health cannot manage and resolve, if I could use that word, alone by any means. We also in Vermont heavily rely on our socio-ecologic framework. This one is now adapted to diabetes, but the reality is we look at most of the problems we have in that way, and this helps us actually build a foundation that is heavily oriented to social determinants and health equity. So we have a continuum of our state health assessment, our state health improvement plan, health equity, social determinants of health, a investment in health and all policies, which really means a cross-government sector approach to every problem. You heard in the previous presentation a little bit about transportation. So obviously we work with our agency of transportation, and if something is going to be constructed in terms of a road or what have you, bottom line is it better serve multiple purposes, not just getting people from one place to another, but making sure that the other place includes a place like a park that could actually be a focus for physical activity, and that the pathway has bike paths and walking in mind. And then, of course, accountable communities for health. All of this is a combined and major effort to enact a vision. The vision is really, this is not our slide. This comes from San Francisco, but it's been used in multiple venues. The right-hand part of the slide is the most downstream aspect, which is really where the healthcare system is and where public health positions itself in terms of calling out and managing risky behaviors. But obviously, the public health framework for reducing inequities moves upstream to the living conditions section, which of course is the so-called proverbial social determinants of health, and then moves even further, because that's now called midstream, no longer upstream, to the true upstream, which gets into the whole issue of social and institutional inequities. This is a slide I would never show in an auditorium, but it seems to work really well on a Zoom platform where you can actually read it and make out some of the intentions on it much more clearly. Obviously, everything on the middle and left of the slide requires abundant strategic partnerships to enact, and illustrates again why public health is the catalyst, public health is the champion, public health is leading the effort, but it cannot possibly do all the work. From our state health assessment, we carved out, if you will, 5 sets of critical health conditions, which are listed on the left side: child development, chronic disease, mental health, oral health, and substance use, and said that they cannot be divorced at all from the social conditions on the right hand of the slide if we're going to make any progress in achieving our goals. So we explicitly aligned all of this with a health equity lens called Populations in Focus, which clearly calls out most of those areas where we see the greatest inequities and disparities. Just to give you an example, with again another slide I wouldn't show in an auditorium, in terms of strategies, we sort of bucketed them in investing in policies and infrastructure to create healthy communities. So those are things like policies and norms that encourage activity, healthy eating, et cetera, discourage substance use. The middle bucket is really programs that promote resilience and connection and belonging. So home visiting programs, strengthening families, progress. And then the latter right-hand side is really a community clinical public health connection, heavy lifting things like integrating mental health, oral health, substance use into primary care, et cetera. All on a foundation of course, organizational and institutional practices that advance equity. So I was told to show you a lot of vision, and obviously I can't go into huge detail, but I will at the end of the presentation carve out a few details. Now comes the pandemic, and what all of a sudden becomes health equity 101 class for the whole country's population. So my one slide I've chose to show what happened in the pandemic, again, illustrates that marked difference in rates seen in the middle of the slide of cases of COVID in the BIPOC population versus the white non-Hispanic. It's also a significant disparity in the hospitalization rate and in some of the predisposing conditions that this slide illustrates. So when we saw this, as did the whole world for that matter, and certainly the whole country, we started out by recognizing we could not reverse some of the centuries, if I could say, of historic injustice, just because we had this data now. So we really opted to work on what we could have an immediate impact on. One thing that was very obvious is we had all this adverse data, and we had a very newly emerging data at the beginning of this year on our success, I'll put in quotes, in vaccinating populations of color versus the traditional non-Hispanic white population. And you can see there's a gap of about 13% in how we started. Well, we did a lot of work to try to improve upon that. And that involved, needless to say, abundant partnerships, using trusted community advocacy groups to work with us and represent us with their communities, doing a lot of interpretation work for our new American populations and communication and education work, and actually having neighborhood level clinics with, again, trusted entities. And lo and behold, we have almost eliminated the disparity gap completely. But before you pat me on the back, or we pat ourselves on the back, I have to say that even now within there are disparities, because we found that with all aspects of the BIPOC population, except for the indigenous population, we were doing really well. When we look at our Abenaki and other indigenous tribe populations, we still have a significant disparity. So we have work to do. It's never all resolved, and the numbers don't actually tell you that very well. We also said, what else can we do in this effort? So we created a health equity and community engagement team, which was a fundamental process for us. It required a tremendous amount of humility, a tremendous amount of self-introspection, if you will, and then developing a team that could work well as partners and as collaborators across the state and enhance the Health Operations Center's response strategies in the education, prevention, and outbreak response arenas, and basically focused with a health equity lens on those priority populations and those partnerships and the communication needed. And that's obviously a work in progress. Like I said before, you don't reverse centuries of historical injustice with a move here, a move there. But this is not only symbolic, but this is really a critical cog in the machinery now to really help advance the work we can do in health equity. Now we get to the post-pandemic challenges, some of which you've heard this afternoon, and I will reiterate. Obviously, over the past several decades, emergency preparedness and pandemic preparedness has had significant problems with chronic underfunding and defunding on a graduated basis. Our public workforce has been eroded instead of enhanced, and we don't have modernized data systems. They have been tremendously underinvested in. It's great to say that all these bullets that I've just given you are being attended to by all of the recent funding that is pouring into health departments. But that funding needs to be not short-sighted. It needs to be sustainable and not just a couple years and see what you can do. George Benjamin of the Umbrella Organization for Public Health basically says the public health budget needs to grow by $7 billion to address those new and chronic diseases you saw on an earlier slide in the New Hampshire presentation. But that's really an investment that's worthwhile when the cost of uncontrolled pandemics is in the trillions. And then, of course, many of us are very sensitive to the MMWR from the summertime, showing horrific, I would call it, impact on the mental health of our workforce. Large percentage reporting symptoms of at least one mental health condition. The conditions included anxiety, depression, post-traumatic stress, suicidal ideation, very serious stuff. So it's challenges like these that now will bring me back in the final part of my talk to the vision and help further craft and refine the vision. I'm going to give you an incomplete list just to keep it manageable, but it provides plenty to reflect upon, especially in your discussion periods, and to demonstrate a response to the challenges I posed. Obviously, chronic disease is high on the list, not just because I'm an internal medicine physician, but because I also know that 80 cents plus of every healthcare dollar goes to chronic diseases. And it's now more important than ever because of the concept of health debt. Health debt really is defined as the accumulated impact of changes in health behaviors during the pandemic. that will end up having long-term negative effects on health. So just think about what happened to what's in the first bullet: physical inactivity, nutrition, adverse maladaptive responses to stress in terms of substance use. In Vermont, our program is called 3450, the 3 adverse behaviors that lead to the 4 chronic diseases: diabetes, heart disease, lung disease, cancer, that account for well over 50% of our deaths every year. And that needs to be further sustained and blossom even more. Then we look at more mental health and substance use disorders that we've discussed in this slide and the previous one, across the age spectrum, from our very youngest to even our very oldest. The statistics that we see accumulating on diseases of despair, whether they be opioid overdose deaths, whether they be alcoholic liver disease, whether they be suicide, etc. The environmental health aspects of our society that we are learning more about every day, what we have done to this planet, now compounded by and further amplified by climate change. And climate change is really such a big ticket item right now. So take a pandemic, and that is a crisis that leads to opportunity. And that's where our opportunity is, in this range right here. And we've seen the governmental attention to climate change and mental health and historical racial injustice just as a result of the pandemic. So don't minimize that opportunity. And then finally on this slide, preventing adverse childhood experiences, building resilience in our kids and our families. We have a vision for really sustained, evidence-based home visiting for all Medicaid families who could benefit, making sure that all of them have access to this, which would be a game changer in our state, and we are headed in that direction. Obviously, a better informed look at health equity. We need to have the humility that's appropriate because we're all in this together, and cultural humility should really be something we lead with and are honest about. Ask our partners to lead. We don't have to be the leader. We can catalyze their ability to lead. We can interact with them in new ways. Instead of us saying, we've got grants, we've got the resources, this is the program we are unveiling, we can change that equation a little and say we can bring the resources that are needed and actually acknowledge that you may know better how to use them, so we can work with you as partners and help you use them in better ways. Obviously, significant relationship building and trust, enhancing the capacity of these community organizations, and then, of course, the health equity and community engagement team I illustrated. Brings me back in the conclusion to the theme of the talk. Again, every aspect of vision that I've presented from the past and the present really, and the future, is really informed by health equity and must be. This is the future of public health. I think all of us in public health know this. We can have some great statistics in our state on you name it. But once we start digging down into the data and look at where the disparities are, they are profound. So hopefully we can all enact this public health framework for reducing health inequities that I illustrated previously and just reinforce here now. Thanks for your attention, and we look forward to the kind of feedback you're going to give after your discussions.